So our last talk for the day and well for the Congress is by Jefferson Bear, who's going to be talking about preventive cardiology. So I know he's ready and up and running. The top button is the green. Let's see here. We just push this in.
It's on. Hello, hello.
Good, and it should be on. It takes like a couple seconds. But okay. All right, great. Thank you.
So I'm a little bit of an outsider here, it looks like. But I think there is a lot of overlap between cardiology and endocrinology, and so we'll go through some of these slides. I'm going to talk for about 25, 30 minutes. Everybody can hear. Sounds like it's not on. Hello, hello. I don't think it's on. It is? Oh, okay. Sorry about that. Is that better? Can you guys hear me now? At all? Can you hear? Is it better? No? All right, I don't know if somebody can. Yes, there's a green light on, but the mic? Okay, I can do that. It still doesn't sound like it's on. Better, better, better? Okay. All right, so I'm going to talk for about 25, 30 minutes, and then we'll have time for questions. I don't know exactly what endocrinologists want to hear about cardiology, so that's why we'll leave some time at the end to kind of talk about things. And I also want to preface my talk with I'm not going to be talking about exercise and diet and those things. That's not because I don't believe in them, I do, but there's just not enough time to discuss all those topics. So I don't have any disclosures for this talk. This is kind of what started out with cardiovascular disease and diabetes. This is a study that was published in 1998, so a long time ago. And basically what they found was they looked at people, non-diabetic patients with no prior MI, and then looked at patients who had prior MI and looked at their risk, their 7-year risk of having recurrent MIs. And then they compared them to the diabetic patients. And what they found was if you were non-diabetic and had coronary disease, your risk was the same as patients with diabetes who did not have a history of coronary disease in the past. So that's what started this whole idea that diabetes is a coronary artery disease risk equivalent. So from this study, people have basically treated people with diabetes as having coronary disease for the most part. Now, I will tell you that this has been called into question. This has not been replicated in future studies, and it's very controversial. So we've kind of gone a little bit away of thinking about patients who have diabetes as having coronary disease, but I think we can all agree that their risk is increased compared to people without diabetes. So here's the outline. Talk a little bit about hypertension. I know you guys aren't treating hypertension, but you probably see this in clinic and wonder, what am I supposed to do about this? And so I'll give you some ideas. Lipids, and then talk about aspirin. And this is, again, in primary prevention. So this is people who don't have diabetic patients who don't yet have coronary disease. So let's talk about hypertension. So this is a study that came out about 10 years ago, and they basically looked at patients' blood pressures and followed them over many years and looked to see who had the lowest risk. And what they found was really optimal blood pressure was 108/70. Normal blood pressure was considered 122/70, and then high was 132/80. The point here is our idea of what normal blood pressure is a lot lower probably than what you previously thought. And this was shown in both men and women. And because of this, a lot of people began to look at, well, maybe we should be treating people with normal blood pressure to even lower targets. And so this was the ACCORD trial. And I bring this up because this was in diabetic patients, so you guys probably know it pretty well. So this is a randomized trial that looked at targeting blood pressure targets of less than 120 versus less than 140, only in type 2 diabetic patients, very large trial. And so what they found is they compared basically blood pressures 130 versus 119. So the intervention worked. It did lower blood pressures nicely in both systolic and the diastolic arm. And what did they find? What they found was in terms of the primary endpoint, which was a triple endpoint of non-fatal MI, non-fatal stroke, and cardiovascular death, was that there was no difference between those who had more intensive blood pressure versus standard. However, if you look at stroke risk, dramatic reduction in your risk of stroke. So there's a 60% relative risk reduction for patients with stroke, for patients having recurrent stroke. So I actually don't view this as a negative trial. That's the way it was released, was a negative trial. But I will tell you, this p-value was almost statistically significant. It was an underpowered trial. And if you told patients, I can reduce your risk of having a stroke by 60%, I'm not sure of any patient out there that wouldn't want that treatment. So I view this as a positive trial, but it was billed as in patients with type 2 diabetes at high risk for cardiovascular disease, targeting blood pressure less than 120 compared to 140 did not reduce the rate of composite endpoints. So there's a little bit of disagreement about this, and I'll come back to this in just a second. So people still had this idea that lowering blood pressure was going to be superior, and so the SPRINT trial, which is really the 800-pound gorilla in the room, was performed and released several years ago, and this was, I think, about 10,000 patients, similar to ACCORD in terms of the goal blood pressures, but this was not necessarily in diabetics. So here it is. They basically randomized patients to less than 120 versus less than 140, about 10,000 patients. And it was stopped early after 3.2 years of a total of 5-year follow-up because of a risk reduction, which we'll show you here. So here's who they looked at. They looked at patients greater than 50, systolic blood pressures between 130 and 180. They had to have one additional risk factor. So either they had to have subclinical cardiovascular disease, CKD, high Framingham risk, or age greater than 75. The reason this is important is that these are probably higher risk patients than were studied in the ACCORD, and that's probably why this was positive and the ACCORD was, kind of, quote, negative. So here is the outcomes: 25% lower risk of cardiovascular events in the intensive blood pressure lowering arm compared to the standard. And this was even more shocking. There was a 27% lower risk of mortality. That's pretty hard to do, to show a mortality benefit in this day and age of patients being treated for all of their different medical conditions pretty aggressively. This trial actually showed a 27% relative risk of mortality in people who got their blood pressures lower than people who had the standard of care. So because of the SPRINT trial, the ACC, AHA, and several other organizations came out with revised blood pressure guidelines just several years ago. And we'll just go through these quickly. So basically, they were somewhat controversial because they're much more aggressive than in the past. So now what is considered normal is less than 120 over 80. Elevated is a vague kind of term. What does that mean, elevated? But it's 120 to 129. High blood pressure is now 130 to 139, and then high blood pressure stage 2 is greater than 140. So this is completely different from the other guidelines. And I will say that there's not complete agreement about this. There are other groups that did not endorse this. And so there's some discussion points you could have about it. So this is a busy slide. I'm not going to go through all of this, but I think there's a really important point to be made here. Normal blood pressure obviously promote healthy lifestyles. That makes sense. The elevated group, the ones between 120 and 129, non-pharmacological therapies, so again, low sodium diets, exercise, weight loss, all those things that you guys know. The really interesting group is this stage 1 hypertension, so between 130 and 139. What they're doing is they're saying calculate an ASCVD risk. If their 10-year risk is greater than 10%, treat it with medications. If it's not, then do the regular lifestyle modifications. And I think that's what is really interesting, because I think what we've determined now is that one size does not fit all. And that may be true for a lot of different things in medicine, but it's definitely true for blood pressure. It's probably true for cholesterol as well, is we need to target the high-risk patients and lower their blood pressure more aggressively. But the lower-risk patients, you might not need to be that aggressive. And in the past, we kind of had one number, and that was supposed to work for everybody. So what I think you're going to see in the future is a lot more of assessing patients' risk and then deciding kind of how aggressive to be about a lot of different factors. And actually, I'm just kind of curious, how many of you guys calculate this ASCVD risk? You have these, yeah. So a decent number. I mean, I think it's very effective. You can get it on a smartphone. You can get it on the computer. You just put their information in, and it gives you a 10-year risk. It's very helpful. It gives patients some idea of their risks that may motivate them, and it helps you kind of tailor therapy for that individual patient. So this was an interesting trial that basically took the ACCORD data, and they examined it by excluding excluding ineligible. Yeah, so they took the ACCORD data and they only included the patients that would have been eligible for the SPRINT trial, meaning higher risk patients, because SPRINT trial was much higher risk than ACCORD. And then they looked at what happened in terms of the standard blood pressure versus intensive. And what they found was that it worked, that you had lower lower cardiovascular events in the lower blood pressure group than the standard group in type 2 diabetic patients. The point here is that ACCORD was probably too low a risk to show a difference and was underpowered. And if you looked at higher risk patients, those patients tended to benefit from more aggressive blood pressure targets. So the question becomes, well, what is a higher risk patient? I think there's some debate about that. I would say the ASCVD 10-year risk greater than 10%, maybe, greater than 20% for sure. So in my practice, what I tend to do is if their ASCVD risk is greater than 20%, I'm definitely more aggressive with blood pressure. If they're 10% or higher, I kind of have a discussion with a patient to decide kind of what they want to do, what their goals are. Are they old and frail, and are they going to fall if you're more aggressive with blood pressure, or are they kind of younger, healthier, and they can tolerate it? Now, I know you guys aren't necessarily treating hypertension, but I think that what you can do in these kind of situations, if you see somebody's blood pressure running higher than you would like, tell them to talk to their primary care doctor, send them to a cardiologist who would be interested in treating this, because I know you might not be specifically managing their hypertension. So in terms of the summary, I would say one size does not fit all in hypertension. Assess their ASCVD risk. For higher risk patients, aim for a goal blood pressure less than 130/80. Lower risk patients aim for a blood pressure of less than 140/90. And again, the high risk is kind of up for debate, somewhere between 10 to 20% ASCVD risk in 10 years. All right, so let's talk about lipids. We were just having a discussion earlier about whether you guys are interested in lipids, don't want to treat them. I never know, because I think that's an area where cardiology and endocrinology kind of overlap. So we just had our newest guidelines released about a week ago, and so I'm just going to go through them. They're not that different than they were before, but we'll just talk about it briefly in terms of how it relates to diabetic patients. So the 1A recommendation is that in all patients 40 to 75 years of age with diabetes, regardless of their 10-year risk, should be on a moderate, intense statin therapy. That's kind of the way it was in the past, and not much has changed. Everything else is either a 2A or 2B recommendation, which is saying there's not as much data for it. It's not as well established. In patients with diabetes who have multiple ASCVD risk factors, it's reasonable to prescribe high-intensity statin with the aim to reduce LDL levels by more than 50%. The point here is if you have a diabetic patient who's very high risk, you're going to be more aggressive with statin therapy. You want to get their LDLs down lower than maybe somebody who's a lower-risk diabetic patient. And then what's saying here is that in patients with diabetes and high 10-year risk greater than 20%, you may want to add Zetia. How many of you guys use Zetia? So yeah, so you guys are comfortable with using Zetia. I mean, I'm not I think Zetia has a definite role. I definitely maximize statins and titrate them as high as we can get them in terms of side effects. And then if we're not quite at the goal where we want to be, then I add Zetia on top of that, or things like fibrates, which we can get to in a little bit. So the issue with lipids, I think, is that everybody thinks, oh, I put them on a statin, my job is done. And I think there's this whole concept of residual risk that people forget about. These are a bunch of trials that have been done for over a long period of time, and the point here is that this is placebo and this is statin, placebo, statin, and so on and so forth. And what you see here is everybody feels really good. You put them on a statin, you feel like, oh, great, I've reduced their risk of coronary disease. The problem is, look at how much residual risk is here. These are recurrent cardiovascular events in people taking statins, and it ranges anywhere between 5 to 20%. So then you say, well, okay, just give them more statins. These were incredibly intensive statin therapies, getting LDLs down to 62, 81, 71. You still had this residual cardiovascular risk despite aggressive statin therapy. And if you look at diabetic patients, it's even worse. So these are diabetic patients here on statins versus placebo. This is recurrent cardiovascular risk, anywhere from 10 to 30%. So the point here I'm trying to make is that just putting them on a statin is not enough. And I see this constantly in my practice where people come in, they have diabetes or not diabetes, they're on maximal dose statin, they keep having recurrent events, and we kind of think our job is done. And I think here is an opportunity where in the future we're going to have more treatments that can potentially lower this residual risk even further. So what are the possible therapeutic targets we can look at? There's HDL cholesterol, triglycerides, non-HDL, ApoB, and Lp(a). I don't have time to talk about all these, so we'll just go through a couple of them just real briefly, and if people have questions later, we can go through that. So this is the way I felt like when I used to give talks about HDL cholesterol. We were talking about niacin. Everybody was really into it. We thought it was going to lower risk, and here's what it feels like to talk about it now. Nobody really cares about niacin. People think HDL doesn't matter anymore, and that's because of the AIM-HIGH trial. So the AIM High trial was several years ago, which basically looked at people with low HDL, putting them on niacin versus placebo, and it didn't work. I think, though, there's a lot to talk about here, but we don't have that much time. My main point is, yeah, we're not treating it with niacin, but don't ignore it. This is a marker for high-risk patients. So if you see somebody with an HDL of 20, you can't ignore it. You got to get on them for, start exercising, get their sugars under better control, diet, whatever it is, but don't ignore this. And in fact, I had a patient the other day. He was, I think, 42, had triple vessel coronary disease, needed CABG, and his only real risk factor was his HDL was 20. I mean, he was overweight. He had maybe metabolic syndrome, those things. His HDL was 20. So I think it really does matter. So in these patients, you really want to aim for very low LDL cholesterol in these patients and really encourage them to do all the other things that we know lower cardiovascular risk. Now, an interesting subgroup analysis was done in the AIM High trial where they took patients who had elevated triglycerides and low HDL. And in fact, in that group, niacin worked. 36% reduction in cardiovascular events, and it was statistically significant. Now, I know this is a subgroup analysis, and we can't put that much stock in it, but I think there is something there with triglycerides, and that's where the story gets kind of interesting, I think. So what about triglycerides? There's been this long debate about whether they matter, do they not matter, are they just a marker for other things? I think at this point, it's pretty clear that they do matter. This is multiple studies done over many years, and there was an elevated risk for people who had elevated triglycerides. So this is just one trial. I'm not going to go through a lot of these, but this was the AIM High trial, the VA HIT trial, which looked at 2,500 men with CAD not on a statin. So this is pre-statin era. And they randomized them to gemfibrozil versus placebo. They had low HDL. LDL was kind of like, not great, not terrible. And they had mean triglycerides of 160, and they followed them for 5 years. And here's what they found. There was actually a benefit of gemfibrozil versus placebo. And it was statistically significant. So there's something there. The problem with fibrates, right, is that they kind of do everything. They raise your HDL, they lower your LDL, they get your triglycerides down. So you don't really know, what was it that worked. But clearly fibrates have some kind of risk reduction. But again, this was in patients who were not on statins. So fibrates are kind of forgotten about now because everybody just does statins instead. So this was all the trials looking at fibrates in people who had elevated triglycerides. And what's interesting here is if you just looked at their primary outcome, it wasn't really very impressive. It was, for the most part, kind of neutral. But if you looked at only the patients who had elevated triglycerides above 200, dramatic relative risk reduction here. So I think part of the problem with fibrates and triglycerides in general is we've not really looked at people who have high triglycerides. The trials just haven't been done. There are a couple that are ongoing now, which we're going to get answers to, but there really aren't a lot of trials to tell us what to do. This is your organization. This is the American Academy of Clinical Endocrinology, and they basically said fibrates may improve outcomes in primary and secondary prevention when triglyceride concentrations are greater than 200 and HDL concentrations are less than 40. And this is kind of what I do. If I have my patients who keep having cardiovascular events and they have high triglycerides but their LDLs look good, I put them on a fibrate. Maybe I put them on Zeti on top of that. Maybe put them on niacin. Fibrates tend to be the easiest ones that are the best tolerated. So this is a slide. This is a busy slide. I'm not going to go through it. This is a review paper I did for ACC a couple years ago, basically looking at the LDL targets for patients and using what you guys came up with. And I will say your guidelines are ahead of ACC, much more aggressive, and it's kind of more in line with what I treat. And then the European Cardiovascular Society came out with their own set. So this is something that's kind of nice. It gives you targets for LDL, non-HDL cholesterol, which I don't really have time to talk about, and ApoB levels. And so if you want me to email you this slide, it's kind of nice to have in your office, and you can target it. It looks at extreme high-risk patients, very high-risk patients, high-risk, moderate, and low-risk. And I think this is the way it's going, really tailoring it to their individual risk. How many people have heard of Vascepa? Yeah, so Vascepa is very interesting. This is the whole fish oil story, which, I mean, you could have hours and hours talks about fish oils. This is the newest kid on the block. It's pure EPA, as opposed to most of the other combinations like Lovaza's EPA and DHA. And the reason this is a big deal now, and I wasn't really a believer in Vascepa, but the reason that this is potentially a really big deal is there was a trial that just came out, and it was released about a week ago. And it looked at basically Vascepa in patients with hypertriglyceridemia. And it was called the Reduce It trial, and it's been a really big deal because of this. it basically showed 25% relative risk reduction for patients already on statins with your LDLs about 70. That hasn't been shown other than these new PCSK9 inhibitors ever, that on top of already aggressive statin therapy that you get a 25% relative risk reduction with taking fish oils. So it's a big deal. What's a little bit strange about it is that it didn't seem to matter whether they had high triglycerides or not elevated triglycerides. So there's a lot of talk about what was the mechanism of action. But you're going to hear a lot more about this. It's still quite expensive. I did not prescribe it before, but at this point, this trial is kind of compelling, and so it's going to be interesting where this is going to go from here. So this is just looking at all the different endpoints. All of them were significant except for death from any cause, and that almost got statistical significance. So it was a pretty impressive trial. All right, I think that was a mistake. So talk about aspirin. So aspirin, this is the last part of the talk, and then we can. I skipped over diet because I think you guys have heard enough about that. So aspirin's been very controversial recently. I don't know if you guys follow this, but for a while people were saying, "Oh, just put aspirin in the water. It's great for everything. Everybody should be on aspirin." And then the pendulum has really swung the other way, and people say, "Hey, wait, aspirin. There's definitely risk to aspirin. Let's be careful about this." So which medication has a higher overall risk of serious side effects, aspirin or statin? And I will tell you, in my clinic, I have people coming in, and they do not want to take their statins, but they're like, "Oh, I've been taking an aspirin for the last 10 years." And they think aspirin's benign and think statins are, the devil. And I'm here to say that aspirin's far more dangerous for you than statins. But patients don't get that yet. And I think it's our duty to tell them that statins are really, really safe, and aspirins, while they're relatively safe, they do have some risks which they need to know about. So if you look at aspirin versus statin safety, there's no real obvious direct head-to-head comparison. But basically, statin risk of liver failure is non-existent. It's just no different than placebo. You can get rhabdo, this is true, 0.44 per 10,000 patient years. But if you look at hemorrhagic events in aspirin, 55 per 10,000 patient years. Low number, but way more than statins. And so I keep telling my patients, statins are safe. Aspirin, maybe not as safe as you think, and be careful with it. So this is your guys' recommendation about what to do with aspirin for the primary prevention of cardiovascular events in people with diabetes is the ADA statement. And they basically said, consider low-dose aspirin in all patients with diabetes if their 10-year risk is above 10% a year. So similar to kind of the blood pressure discussion. And they basically say to treat diabetic patients the same as non-diabetic patients. So this was a trial that just got released a couple weeks ago, which was the ASCEND trial, which basically looked at aspirin for primary prevention in people with diabetes and what to do about it. And what they found was quite interesting. So they found a modest risk reduction for cardiovascular events, and then they found an elevated risk of bleeding events. And so what they basically said was that the risk, this was a neutral trial, and the risks don't outweigh the benefit. And it kind of was sold as it was a negative trial, meaning patients with diabetes for primary prevention of cardiovascular disease shouldn't take an aspirin. Now, I would tell you that if you told me I could avoid a heart attack or I could have a bleeding episode, I probably, me personally, would rather have the bleeding than the heart attack. So I think there's some debate about, does this just cancel out? I mean, it's kind of comparing apples to oranges. So I think you have to have a discussion with your patients about it. The other important point here is that these were low-risk patients. So they were only, I think, 17% were high risk. All the rest were low to moderate risk patients. So again, we're going back to that same thing. If you're going to use aspirin, you really want to calculate their ASCVD risk. And if it's high, then there probably is some benefit for aspirin. If it's low, there might not be. This is what the Europeans do, and I really actually like this slide quite a lot. It seems busy, but it really isn't. So this is what they recommend about aspirin. So if you're less than 10% ASCVD risk, stop. There's no role for aspirin. If you're between 10 and 20%, then you go down this path. It says go ahead with caution. And if they have a lot of bleeding risk, stop. No aspirin. But if you go down this pathway and there's no bleeding risk, then maybe low-dose aspirin makes sense. If you're high risk, meaning less than 20%, it says just proceed. That's why it gets green. Proceed. High bleeding risk, then maybe not. But otherwise, go ahead and give them low-dose aspirin. So I think this slide really makes a lot of sense, and that's kind of how I go about it. So you really want to have a discussion with your patients about their bleeding risk. If they do have high bleeding risk and they are high risk for cardiovascular events, It's known that PPIs reduce the recurrent bleeding risk with aspirin dramatically, and so that's what I often do is just give them Prilosec or Prevacid. It's cheap, generic now. It's really easy to take, and then you can probably lower that risk of bleeding significantly. So conclusions, really, I keep hammering this home, but as you want to assess ASCVD risk in all of your diabetic patients when you're trying to think about all these different therapies that you're going to employ. For high-risk patients, aim for blood pressures less than 130/80. Lower-risk patients aim for less than 140/90. Almost all diabetic patients should be on a statin. Now, whether it's a moderate intensity or high intensity, that's going to depend on their ASCVD risk. For your high-risk diabetic patients, me personally, I aim for LDLs less than 70. That's for all my patients. And if you guys get a copy of that slide, it has all the different goal LDLs and non-HDL and those kind of things. It's quite helpful. And then in your higher-risk diabetic patients, I would consider aspirin in primary prevention. Lower-risk diabetic patients, probably no real role for aspirin. You're just subjecting them to risk of bleeding. And this is when I lived in Seattle, and then when we came back, we had one more. So this is them raising their hands for questions. So now I really want to have any kind of questions you have. There are some cases that we could go through. If you are interested, if you just want to ask questions and get out of here, that's also fine. So thanks. Yes. Which trial? Oh, that wasn't a trial. That was a guideline. Sorry. That was a European guideline for aspirin. Yeah, sorry. So the Ascend trial you're talking about. In this trial here? You mean these here? They didn't, I don't remember exactly, it wasn't ASCVD risk, how they calculated this, but it was kind of similar. They used some other risk profile scoring system. But from my standpoint, there's debate about what is high, what's low. It's somewhere between 10 to 20%. Nobody can really agree on that. I think 20% and above is high, personally, and 10 to 20 is intermediate, moderate risk. And this correlated with it somewhat. I don't remember their risk calculator that they used, but it wasn't the ASCVD risk calculator. Yes? Yeah, so that's a good question. I think definitely above 200, then I can say, well, let me step back. If it's a primary prevention patient, they don't have coronary disease, they just have elevated triglycerides, and they're 200 to 500, then I think you just do diet, exercise, low carb diet. You guys know this probably better than I do. If they have cardiovascular disease, like they've had stents, bypass, that kind of thing, then I'm more aggressive. Then my cutoff is 200. I'm doing something about those triglycerides because of that whole residual risk thing we discussed. That's a really good question. Honestly, I probably will be using more Vascepa. I mean, the fibrates, I believe in them inherently, kind of, but there is no trial looking at them with statins that's shown outcome data. And so the only thing we're left with is these kind of subgroup analyses, which there probably is something there to it. But Vascepa, I mean, it's pretty impressive. It's hard to argue with that. The only downside to it is cost. It is expensive. And there was an increased risk of AFib with patients on Vascepa. So there is this whole notion that fish oils do something to the myocardium, and in some trials we think they reduce things like VT, ventricular tachycardia, and that has been one purported mechanism for why this worked. But there has been some questions about AFib as well. So that kind of jury is still out, and obviously that's not a trivial issue. So, yes. Yep, good question. Let me see if I have this slide in here in the sprint trial. I have a lot of slides. Darren was like, don't show all the slides. Let me see if I can find it real quick. So that's a very good question, and I have a slide about the sprint data. Let me see if I can find it. Of course, when I want to, I can't. Oh, well. So there were adverse outcomes in the sprint trial in terms of those lower blood pressure, and increase in creatinine was one of them. There's also hypokalemia, as you can imagine, syncope. So those things did happen. And so my take on it is for my little old lady whose creatinine is borderline, who's frail, who's, you're worried about falls, I'm very, very cautious in those patients. On the other hand, there was a decrease in cardiovascular mortality. So, yes, it's going to require more monitoring. I'm getting more basic metabolic panels looking for hypokalemia. I'm doing a lot more home blood pressure monitoring. That's another big issue, which we didn't have time to talk about. A lot of times in the office, they're 150, and at home, they're 110. So if you're just going off the office blood pressure reading, you're going to get a lot of AKIs and syncope and those kind of things. So the first thing I do is I send patients home with a good blood pressure machine and get them to take a blood pressure diary, and then they send that back to me because I want to confirm that they are, in fact, low or high at home before I start treating them aggressively. So I agree with you that you have to be cautious, and it requires more work. I think that the benefits outweigh the risk, but you're right. You have to be careful. Yes. Yeah, I mean, there's some cardiologists that are like, why are they sending me this patient? They don't have coronary disease. And then there are other people that are interested in this kind of thing. And so I think what it really requires is a partnership with finding, a cardiologist that has an interest in this and wants to see these kind of patients. So I have multiple endocrinologists send me, tons of patients because they just know this is kind of the stuff that I do and I take an interest in it. But you're right. If you send this stuff to an interventional cardiologist, they're going to go, what are they doing? So I think it's a matter of finding the right cardiologist. But it's a good point, yeah. Yeah, good point, yeah. Yeah, so there is, as you guys know, that poorly controlled diabetes causes hypertriglyceridemia. So, yeah, I think that's why the first thing you want to do is you check A1Cs, you check a thyroid before you just start putting them on medications. I just didn't have time to talk about that, but you're absolutely right. If you get their A1Cs under better control, their triglycerides come down. There's also a lot of medicines that cause hypertriglyceridemia. So hydrochlorothiazide does, beta blockers do. So very common medicines can cause triglycerides to go up. So you have to kind of look into those secondary causes of hypertriglyceridemia. So it's a good point. Yes. Yep. I'm just looking for my slide about this. I don't think I have that either. But yeah, it's a really good complaint. So all these myalgias. The first thing I try to tell patients is you're giving up a life-saving medication for these myalgias. And I will tell you from the multiple trials I've looked at this, a lot of these myalgias are not related to the medication. Now, that doesn't convince patients oftentimes, so you have to come up with something else. There are a couple of things I'd say about that. Number one, check a vitamin D. There's been some evidence that low vitamin D, if you treat it, it might help with myalgias. I'm not saying this is completely evidence-based, but there's been some evidence that's helpful. You also want to check thyroids. You also might want to do evaluations for rheumatologic issues. I've picked up a couple polymyalgia rheumaticas from people with muscle aches and pain, so that's one thing to think about. The whole business of coenzyme Q10 that's been out there for a long time, is it help, does it not help? There was a recent meta-analysis that said maybe it does help. I've not been a big believer in it, but this new meta-analysis makes me kind of rethink that. There's not really a huge downside to coenzyme Q10 other than cost. So for my patients who have issues with myalgias, I check a vitamin D, check a thyroid, try to talk to them, de-escalate the dose. So if you had them on a Torva 80, go down to 40. I even do Crestor 5 every other day. They seem to like that. I do Crestor 5 every other day with a little bit of Zetia. I tell them, I use Crestor because I tell them, well, you're just getting 5 milligrams, not 80. And they really like that. So you do all these little tricks. And I find very few patients that I can't get on some amount of statins. But it may be every other day dosing, that kind of thing. Yes? Yeah. 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 No, I think that some patients do have real myalgias. I believe that. But I think when you take all the people with myalgias, I think a smaller percentage than we think have true myalgias from the statins. But it definitely happens. There's no doubt. I've seen it. So, yes. Yeah, so that's a really good question. So the question was, what's the benefit of Vasipa versus just over-the-counter fish oils? A lot of trials have looked at just kind of over-the-counter fish oils, and there have been very mixed results. So this is the only trial with fish oils that has shown a risk reduction in cardiovascular events. Is it really different? I don't know. This is a different formulation. So most fish oils have DHA and EPA, which are two different kinds of fish oils, and they do have different properties, and this is pure EPA. So the company likes to say that this is because it's pure EPA. I don't know. But there is not the clinical trials to support just over-the-counter fish oils currently. I mean, we all know fish oils will reduce triglycerides. So if you get enough fish oils, 4 grams a day, they'll reduce triglycerides. The big question is, does it reduce cardiovascular events? And that we don't know. The only trial we have is the Reduce It, which was using Vasipa. So I would say for me, if I was going to use a fish oil, it would be Vasipa. Vlovaz, they've done them, but they did it for like 1 gram a day, and they weren't positive. So, I think they're ongoing. There's now a lot of interest. This stock was trading at like $1 a share, and after this trial came out, it's went up 400% or something. So a lot of people got rich off of this. I don't own any Vasipa stock. I wish I did. So I think we're going to hear a lot more about fish oils. I think this has generated a lot of interest, and you're going to hear a lot more about it in the next 5 years. All right. Thank you.
Something I don't do this kind of stuff. Well, I don't know. I may have done this already. But I'd say yeah. Kind of good. Inside the house. And the same problem with I think that was
But I do a lot of calcium scoring. I do, especially in people who are sedentary, like pushing into class, doing exercising all day long. But people who are sedentary, and I will say, I do think about it.
yeah, I'd say I did. Okay, I didn't know if you wanted to stay here or go in the sunshine.
Yes. Yeah. Good idea.
Yeah, let's go sit in the sunshine. I'm not going to be able to see it.
Great to see you. Have a safe trip home. I'm sorry you needed your jacket and
There may be
yeah, you definitely needed to get off school.
There's this risk of spending a
We'll
lot.
look to see you
So
this
they
spring.
are on it for a year, and at that point, stop the violence and just continue that.
Yeah, and you both been on medication, right?
My goal is to go to
Yeah.
And I would let the cardiologists, they'll be very meticulous.
Yeah, sure. They had you already in the program.
They should be on dual therapy.
Yeah, so we got invited to that part. Oh, you too. Yeah, me too.
So, that's interesting. You know, I think we see these because there is evidence that's also highly so the no choice. There's a lot of fun that so also came out with once a day dosing and just twice a day, and that the company wanted to do once a day, so they would say we're going to do twice a day. And so how they overcome this, they give us a huge dose, and then it gradually goes down over the course of the day, and have a higher daily dose when they take this. So I personally think I would just as a safer dose. And that's what I do. Yeah, absolutely.
That was great.
Oh, good. I hope I provided some kind of.
And you came very highly recommended by Larry, so I knew it was going to go good.
Yeah. Well, I'm happy to do it again next year if you guys do it.
Yeah.
And we can do more cases if you want. You guys can tell me, hey, this didn't work about this talk. I'd like to do something else.
I think it's the sort of thing. I think the whole diabetes prevention thing a few years ago was a hot topic, and it was just ignored. It's not ignored anymore.
Okay.
It hasn't jumped the shark, but it's definitely already a part of what we do.
When I talk about calcium scoring or those things, people want.
But the next things are
Yeah, that's one thing, but then again, the audience here, there are a lot of dietitian and nurses. Case stories. Right.
Well, just let me know. So.
Yeah, I think, and as things change, I think they should either expand or change. And we'll see.
Okay. Right.
That's what my conversation with the organizer
Yeah.
said. Yeah, you gotta choose things wisely, but also choose strengths that you have available. So we have the preventive cardiology program at Emory is completely unique. But when I describe it to other people, I know that all our preventive cardiologists also cast. But they have this whole program that really works.
Well, yes. So let us know how you want to be involved. You guys take care.
Thank you for everything.
Yeah, you too.
Yeah, much easier. I was thinking hopefully everything will be okay out there. Good to meet you, ladies. They're all like, well, they got Ace has one guy, and they have like 7 weeks. Where? Ace. What is it, Florida? I don't know. AMA has that regional conference. Nice meeting you, ladies. Yeah, nice to meet you. A bottle of water. People clear any fast with getting our kids on any kind of. No. Well, if I hear anything, it's too bad. Are they doing studies or they're not even doing studies? You need some milk pods? No, I'm always carrying them. That's after the garbage out. It's amazing how you're doing service. With like we said, with our can't use metformin or insulin because of the. What I see is just, I think I'm If you need to get in here, I'm.
No, we're fine, we're fine. I was just making sure everybody's stuff is cleared out. Everyone's happy.
Oh, well, good luck with that.
Yeah. At least they're not yelling at me, so.
Oh, okay.